Join me in welcoming Wilson Compton to our conference.
Well, good morning, everybody. Good morning. It's a pleasure to be with you, and I was glad to sit in on the last session for several reasons. One, it was really gratifying to see some of the materials that my agency has been developing and promoting over the years referenced. And the principles of drug abuse treatment were one of our proudest accomplishments in terms of trying to synthesize sort of basic knowledge about how to implement treatment for substance abusing persons across this country and anywhere. And trying to figure out what we know, but there always is a converse to that. What don't we know? And so what I really appreciated in the last session was this idea of trying to adopt evidence-based practices where you have them, trying to take those that look like they might work and are from something related, and so with a little adjustment, a little tailoring, might work for your particular settings because they're about as close as you can find and they're addressing a target that you really desperately need to target. But also constantly to be pushing for expanding the knowledge base. And frankly, that's what I do for a living. I'm in the knowledge development business, and that's what our agency does. And it also means that we're not always the best with service delivery audiences because you need infrastructure that you can have for a long time. And I'm in the business of answering a question, and as soon as I've answered it, I thank you very much, and I move on to the next question. But we have to work with you to understand how best we can implement new and promising interventions. And I was intrigued, and really I want to congratulate you for so carefully focusing on these implementation issues. They're not thought of very much, and that's what my services research program is all about, is looking at how do we understand the dynamics of implementing evidence-based practices. At the NIH, we sometimes have a sort of field of dreams approach to implementation. My version of that is, I publish it in the Journal of the American Medical Association, and you will do it. What we've learned through a school of hard knocks is that it's developing that intervention is obviously an essential piece. And I would change some of the previous language around, would you share your manual? Yes, because that might interest somebody enough that they'd be willing to take the next steps. But having a manual is kind of like having that research article. That doesn't really tell you what you have to do and help you with that long process of understanding your organizational climate and working with that to make sure that you can implement it, making sure that you have the right personnel involved, that your clinician, for me it would be clinicians, for you all it's probation, parole, court staff, and others, are willing and able to participate in it. Are your clients, are the offenders geared up and ready to participate? If they're not mentally able to respond to your intervention, it won't work, no matter how much it looks like it should work. So all these external factors play a major role, and that's some of what we've been learning and trying to address. Now, I've got a slightly different lesson for you today, and we're going to step back a little bit and focus quite a bit on neuroscience and what some of the neuroscience can teach us about the basic underpinnings of the brain, how that relates to addiction, and how that in some ways relates to crime more generally. Now, of course, I come from the National Institute on Drug Abuse, so my focus will be on the substance abuse aspects of these conditions and on the patients you deal with. That is a major part of your programs, either directly or indirectly. So what I'll particularly emphasize is that it's a combined public health, public safety approach that looks like it's the most effective. What we've done in our country is have quite separate domains where I ran a drug treatment program. Other people run corrections facilities. We often, we certainly shared patients or offenders back and forth, but we often didn't speak to one another and didn't coordinate our activity. And it's through that process of coordination is a major lesson that we've learned through that school of hard knocks in the last few years. What I handed out to you, or had handed out to you, is an excerpt from a pamphlet that we have available on our web, and it's the Principles of Drug Abuse Treatment for Criminal Justice Populations. So it's that document that you heard referred to earlier, but it's been modified so that it targets your people. So I hope you'll find these principles should resonate for you and provide some learning, and will be the basis for what I'm going to talk to you about in the next few minutes. Now, as you all well know, drugs and crime are linked. I include this slide just by a quick background, and it's the kind of thing that can be useful if you have to speak to the public or to legislators. In particular, I highlight the last couple of items. One, these are very costly conditions. That drug abuse is has a lot of healthcare costs and social costs, but one of the major drivers of that are the criminal justice related expenses that are related to addiction. These are very common conditions in an imprisoned or in jail and prison populations with, depending on how you classify and count cases, 40 to 50% will have a diagnosable substance use disorder. So an abuse or dependence, I'm a psychiatrist so I use those DSM terms, have abuse or dependence on one or more illegal or illicit substance. If you include data around the number of people who use substances at the time of their criminal offense, it's an even larger number. But that doesn't mean all offenders have these problems, and as I heard earlier, you need to carefully assess people to determine whether substance abuse treatment would be a reasonable approach. I think of this in the case of, I worked a little bit with a drug court in St. Louis, where occasionally they'd get offenders who were drug salesmen. They were drug dealers in St. Louis, and some of them had a significant addiction, and it made sense to engage them in drug treatment. Others, they really weren't using it all. It was how they organized their lives in terms of making a living. So the idea of drug treatment being appropriate for them was kind of far-fetched. But in many cases, these things obviously go together. Another major factor that's garnered my attention, and I think should garner yours, is the risk for serious morbidity and mortality. That means injury and death for persons with addictions. In particular, I highlight this study that came out a few years ago looking at the chances of dying in the first 2 weeks after being released from prison, and showing that there's about a 12-fold increased risk of death for overdose. So a direct issue related to the addiction issues that I'm going to talk about. And these are life and death matters, particularly during the early reentry phase, which is a very high-risk period of time for problems. Our correctional population has increased dramatically over the last 30 years. Recent estimates are for over 8 million individuals adults involved in criminal justice system in one point or another, obviously mostly in probation or parole. Out of that population, Faye Taxman and colleagues estimated about 5.6 million have a diagnosable substance abuse or dependence condition, but only about 8% of them receive treatment. When we look at adolescents, it's slightly better, but still grossly inadequate. About 250,000 juveniles would qualify for drug abuse treatment, and yet only about 20% of those would be engaged in treatment at any time. So there's a tremendous opportunity for improving our systems of care, and I'm sure many of you in the room can attest to these inadequacies of our systems right now. So that's why we're bringing attention to it. Now, I also, for wider audiences, and frankly for me, this was an incredibly helpful slide to remind me and remind others of all the places in this trajectory within the criminal justice system that interventions can be implemented. Whether that's a screening and referral process right at the arrest or pretrial phase, whether that's at the other end, at community reentry, certainly a very high-risk period for public safety, and one where we're paying a lot of attention as the Second Chance Act and so forth, because of the tremendous number of people re-entering our community, and frankly, we want to keep them in the community and not have it be a revolving door. So what can we do that's smarter and more effective at all the different places along this spectrum? There are many opportunities. So I think you could find creative places to implement programs all along this continuum. Now, my major theme is that so far we have separated our public health approaches, which mostly focus on sort of treatment issues and diagnosing people with an addiction disease. The problem with that is that a lot of my patients drop out of treatment, so we have a very high rate of attrition in drug treatment programs generally. Public safety approaches have been our major policy approach in this country over the last 30 years to drug abuse, and particularly the illegal drugs over the last 30 years. And the idea was you lock people up or you arrest them and punish them. Well, of course they're going to stop. They don't want to get arrested. They don't want to go to jail, so they will stop their behavior. Now, what we've learned is that that hasn't been very effective. There's tremendously high recidivism. People do not learn a lesson simply from being incarcerated, that there's it takes a much more sophisticated approach to help people change the behavior. And that's where our current models that we think are more likely to be effective for a number of individuals. I'm using terms like more likely, a number of people, because we don't have a one-size-fits-all set of programs here. We don't have a one-size-fits-all set of principles even. We need to think about tailoring these to individual needs, and we'll come to that as one of the concepts here. But in general, combining these two major approaches, we think leads to some major innovations. Emphasizing community-based treatment, clearly an opportunity to avoid incarceration and clear their record if you're talking about pretrial interventions. Particularly from the public safety community, I like the idea of close supervision and being able to harness that in a process of behavior change. Another key element will be consequences for noncompliance or misbehavior are immediate and certain. The way our justice system is set up, I heard something about, well, should you violate somebody for having a positive drug screen? Well, sometimes they're going to. If someone is violated, it might take weeks to months before anything really happens to them. They may get a court date that gets postponed several times. Before they end up back in prison or back in jail, it could be a long time. If what we're trying to do is shape behavior, imagine if you were shaping your children's behavior by saying, okay, I told you not to cross that dangerous road. You did it anyway. Next week, I'm going to punish you. Wouldn't really do much to changing behavior. So that's sort of, everybody can identify with parents, with being a parent or having parents, and knows the importance of immediate interventions if they're going to make a difference. That's one of the basic principles that we've learned in psychology and learned in a lot of scientific studies that can be applied. I mentioned our publication. You've got an excerpt there. It's available on our website. And I'm going to go over not all of the principles, but just highlight a few of them for you. In particular, we start out by emphasizing drug addiction as a brain disease that affects behavior. So what is addiction? Certainly a common disease. The term epidemiology is derived from the same word as epidemic. And that's what I do. I count things. I understand the spread and extent of disease in the community. So for instance, there's around 9% of individuals ages 12 and older in our country who abuse an illegal substance during any given month. That means well over 20 million individuals abuse substances at any time in our country. So these are at least the behaviors that lead to addiction, drug use, are very common. The key factor in terms of differentiating somebody who uses versus somebody who has an addiction problem is they continue that drug use or that substance use despite negative consequences. In the most extreme cases, even though they've been locked up, had their freedom taken away, had all their social contacts taken away, and their families taken away from them, they keep using. I certainly remember seeing patients during my medical training who kept smoking through their trach tube after having a larynx removed. Well, that was a pretty visual and visceral reminder of somebody who was so addicted that even though they had the most serious consequence of a cancer diagnosis, they kept using. And you see that all the time with heroin addicts, with cocaine addicts. In the extreme case, it's really obvious. But in more subtle ways, people continue using even though it's interfering with their work. It may be interfering with their ability to be effective parents, interfering with their health in much more mild ways. Not the cancer, but it may start out with coughing or arrhythmias or something relatively mild, and yet they keep using. They sort of put it out of mind and ignore those problems. It's often chronic, and there's certainly a high potential for relapse. Among the patients you're seeing, particularly those involved in criminal justice, the possibility of chronicity is higher. Those who are able to learn a lesson already did so, and they didn't show up in your system. Now, that's not true for general medicine or for the general population. Lots of people change their behavior based on their experience. But you all are seeing those who are a little bit at the tougher end of the spectrum, particularly those with more antisocial traits and more higher criminogenic needs, are also those who tend not to learn from experience as well, have more trouble thinking long term. And so they're going to be more likely to have trouble with conquering addiction as well. Now, I'm going to go through quite a bit of neuroscience with you, but here's sort of the first set of slides that have a key lesson. What you see in front of you are, this is a PET scan. So this is a radio image showing radioactive tracers that go through the bloodstream and show the heart muscle. On the left, you see a healthy heart. So this is sort of a virtual slice across the heart. So the heart muscle is shown in the red and yellow colors. That shows a lot of blood flow and a lot of oxygen consumption throughout the heart, which we want to see. You want a lot of blood flow in the heart muscle. On the right, you see that there's an absence of oxygen and blood flow in certain heart tissue. So that's one of the ways we know that a heart is diseased. You can image it in one way and it looks one way, and we see that as healthy. And the other way indicates less oxygen, less blood flow, and indicates damage and a difference. Just like we can find differences in the hearts using imaging, we can do the same using imaging of the brain comparing addicts and non-addicts. This is a PET scan looking at blood flow and sugar metabolism in different parts of the brain. You're looking down at the head, and it's sort of a slice just a little above the eyes, as if it's a virtual slice right across the forehead. Where that arrow is the front part, and below that is the back part of the brain, so it goes from the front to the back. And what you see is that there's less blood flow in the front parts of the brain of cocaine abusers compared to those who don't abuse cocaine. Well, that's sort of a fundamental lesson, that the brains are different in drug addicts. You all certainly know that the behavior is different, but we're beginning to use our scientific techniques to understand some of these mechanisms for explaining those differences in behavior. Now, I'm going to go through this in some detail to help you understand why those are different and what is it about the brains that are different. But a key message is that there is a difference. So even if you don't follow all the rest of it, that's an important lesson. And you'll follow pieces of this. So here's a key question. Why can't addicts just quit? Well, we've come to learn that there are multiple brain circuits involved in addiction. I'll talk a little bit very quickly about all of these, and you're going to get an overly simplified picture, but it begins to give you a glimpse of the complexity of our brain systems and structure. The reward system is very important. We know that drugs make people feel good. They also relieve pain and discomfort, and that is something we recognize real quickly as mammals and as creatures. We recognize when something feels good or relieves discomfort, and we want to repeat it. So these reward circuits are very important in the onset of drug use. Memory and learning are clearly an important part of it. People have to remember anything that's part of survival, anything that's part of making you feel good or relieving pain. Mostly, those things are good for us. Being uncomfortable because we're hungry and doing something about it is good for us. Seeking the pleasure of sex is good for us. We wouldn't exist as a species if that weren't pleasurable, and if we didn't remember how to obtain those pleasurable activities. So, and certainly drug addicts are really programmed to remember things. I'll show you a little data there. Executive function and control, the ability to resist temptation, is a key part of this paradigm, and certainly motivation and drive, how we express our behavior, is another key part. We put these pieces together in terms of a model, and this is our working model for how we might understand addiction. So a non-addicted brain might be in this way. Let me think about this. I stepped out to go get a cup of coffee, and we won't talk about my coffee habit today, but we will talk about the potential for eating a pastry. I go into the little coffee place down the hall, and there were a number of pastry options. For me in particular, they have oatmeal cookies, and I really like oatmeal cookies. I remember what they taste like. I can picture what they look like, and I can imagine taking a bite out of one and how satisfying that little crunch and then the softness and the sweetness is going to be. That's because I've experienced it before. So I have a good memory for it. Now, this morning I wasn't particularly hungry, so it wasn't so important to me. But even if I'd been real hungry, there's one other thing going on. I'm going to go to my gym this afternoon and see my personal trainer. And she asks me what I've been eating and what I've been doing, so I'm going to have to report. So I'm able to factor that in and resist temptation and say no. Let's think of somebody with addiction. They are coming out of prison. They're going back to their community. They run into their friends. They're not sure what to do with their lives. They're kind of in an unstable point. They're also very excited to be released, and they remember very clearly how pleasurable some of what they experienced might be. So the memories are very primed and strong. They may have an intense desire for pleasure right now because they feel they've been lacking pleasure for many days, weeks, months, or years. In general, the ability to control behavior is diminished in people who are vulnerable to addiction, and this leads to not stopping but engaging in a behavior, even though part of them will perfectly well recognize that it could land them back in jail and cause them all sorts of trouble. These aren't people who are brain damaged to the extent that they don't know what will happen, but they're willing to put it out of mind, and their brains are organized so that they put these things out of mind. So let's talk about what leads to these behaviors. Fundamentally, drugs of abuse engage these reward systems. So this is where we'll start with that first circuit around reward and motivation pathways. I already kind of mentioned, food and sex as major engagers of these reward pathways. These are normal brain pathways that are essential for survival. They are hijacked by all the different drugs of abuse. Colleagues have shown that such drugs as amphetamines stimulate the release of dopamine in these reward circuits. And most of what I'm going to talk to you about this morning is a dopamine story. Dopamine is one of the brain chemicals we have that helps one brain cell communicate with another. So it's released from one cell and taken up by the other, and it produces a downstream cascade of activity. Well, we know that part of the results of the release of dopamine is a sense of reward and attention to something in our environment. So when food is presented, there's a burst of dopamine so that we will remember and it'll become important to us. Amphetamines produce that same burst of dopamine. We actually see this from all the different substances of abuse. I haven't included cannabis because I only wanted to have 4 boxes up here, but I could have included cannabis or alcohol or sedatives among the substances that have all been documented to produce this reward and reinforcement through the dopamine system. So that's number 1. Reward and reinforcement is a key part of the neuroscience of addiction. Second part that I mentioned to you is memory and learning. In 12-step programs, they often talk about high-risk people, places, and things. That's because those are conditioned cues. Those are memories that are firmly embedded in our brains that can produce automatic responses. And let's go into that a little bit. This is a wonderful study done a few years ago in Wisconsin, where they showed individuals movies while they were having their brains imaged using an MRI technique. So this is a magnetic resonance imaging of the brain. And what they did was show, in this case, films of cocaine. So it was, either slides or a brief video showing cocaine being consumed, showing pieces of rock cocaine, showing cocaine paraphernalia. On the left, you see these groups labeled controls. Those are non-users of cocaine who are put in the same paradigm. They're shown pictures of cocaine just to see, well, maybe it's looking at pictures on the screen that produces brain activation. What we see is that those who are cocaine users have a marked activation in certain parts of their brain when exposed to cocaine cues. They also experience craving during that same time. So these cues are important as part of the relapse process. They have an automatic response to, in this case, visual cues. You could have presented auditory cues. Certain sounds will create memories. Smells can do the same thing. So it's a very robust response. We are hardwired in terms of a response to these things. So cocaine users will respond to these cues in the environment. And we can now measure what parts of the brain are active. All right, well, what I found interesting in this study was they also showed erotic films to these individuals, also known as pornography, sexually explicit videos, very short ones, which are, for normal individuals, as you can tell, produce the same kind of activation in these parts of the brain. So this is a common pathway. It's part of the parts of our brain that begins to respond and fire and show activity when there's something interesting in the environment. If you're a drug addict, cocaine is pretty darn interesting to you. If you're a smoker, tobacco cues are pretty darn interesting to you automatically, without you even wanting them to be. They are going to be interesting. I certainly am conditioned around the little green circle of a Starbucks. I think a non-coffee drinker probably doesn't recognize that little green circle as well as I do, but that's an example of how memories produce these imprints, and we can now measure what part of the brain are activated. Well, sex is obviously a very common imprint, and so one of the lessons is it's the same pathways that are important in normal responding that are hijacked and used by the memories that drug addicts suffer with. There's another key lesson here. Look at the orange bars for the drug addicts, the cocaine users. They are lower than for the normal control. So our patients, your clients and the offenders have two issues. One, they have to figure out how to cope with a difficult, automatic, sometimes uncontrollable response to environmental cues. They also don't respond very well to normal pleasurable things. So they have to kind of unlearn one response and learn again how to respond normally to pleasurable things in the environment, whether that's sex or food or being around their family, doing social things, all sorts of things that, of course, are pleasurable for all of us. And we need to help our patients rediscover those. We know that these cues can be experienced even in unconscious ways. They are extraordinarily well wired into our brain and rapidly wired. This is a study out of University of Pennsylvania, and Anna Rose Childress showed slides, showed pictures to addicts of cocaine cues versus nature pictures. The nature pictures don't really do much, but when you show the cocaine cues, they have this activation of certain parts of their brain. She showed those pictures so fast that no one could really tell cognitively what they were looking at. So they were sort of flashed on the screen quite quickly. They knew something had flashed, but they didn't know what it was. They couldn't reliably tell you whether, was that the picture of the Grand Canyon or a tree, or was that the picture of the crack pipe? They couldn't identify which it was. And yet the crack pipe pictures reliably elicited an automatic response in their brain. So it tells us that these parts of our brain are wired quite rapidly and readily from our eyes directly into the automatic response circuits of our brain. Now, some of this is important for us. If something very scary happens, we need to respond quickly. We don't want to have our thinking brain get engaged. If you step off a curb and a bus is coming by, you may find that you've stepped back before you even know what's happened. And it's a couple seconds later when you go, oh my God, I could have gotten run over. It takes a couple seconds for your thinking brain to kick in, but there will be automatic responses well before that. And that's what I think we're seeing, is that the drug addicts, that part of their brain is hardwired in a very rapid manner. Now, I started out by showing you that the front parts of the brain tend to have lower blood flow in the cocaine addicts compared to normal controls. And these dopamine systems seems to be important in this frontal lobe activity as well. These parts of our brain are essential for judgment, decision-making, and what's called by psychologists executive control. Deciding what we want to do, organizing our behavior, and then doing it. So making decisions and then sending those signals to our our motor cortex, our physical part of our brain that tells our hands where to go and our feet where to go and our mouths what to do. But those signals start out with judgment and decision making. So let's look at this a little bit and how dopamine from those deeper circuits might be linked to these frontal lobes. Now for this I have to link a couple of different areas of science. One, there'll be anatomy from neuroanatomists that take cadavers and pick apart the brains and look at how the different cells are physically connected with one another. And we have demonstrated that there are physical connections between those central reward circuits and the front parts of our brain. They're very robust connections. And a lot of these we think are mediated, are organized around these dopamine signals. So I'll walk you through this, hopefully slowly enough that you can follow it, but I'll repeat it a couple of times. One robust finding is that we have lower dopamine activity in addiction. We've seen this for cocaine, methamphetamine, alcohol, and heroin, where the people with addiction have lower levels of dopamine activity in the deep parts of their brain. That's what you see highlighted in red and yellow. There's less of that red and yellow, which is an indicator of a lot of activity in the addicted brains, in those deep reward structures. So that's lesson number one, less dopamine activity. We also know that these front parts of the brain are less active in addicts. All right, so we got two pieces of a story here. The front parts of the brain, which are essential for judgment, decision-making, and control, aren't as active in addicts, which kind of makes sense clinically and in your observations. They don't decide things quite right. They also have differences in their reward circuits. What we've noticed is that these are put together in meaningful ways, so that not only does the anatomy connect those deep reward circuits with the front parts of the brain, but for both cocaine and in this case meth abusers, the number of dopamine circuits is associated with the amount of frontal lobe activity. So those very same people who have low dopamine activity deep in their brains also have a low amount of activity in the front lobes of their brains. And we think that's because those circuits aren't as robust, aren't as well connected. So one of our goals is how can we strengthen those circuits? How can we improve those linkages between the deep reward circuits and the frontal lobes, the control circuits? Parents are doing that all the time with their children. They are teaching control and judgment through a process of practice and repetition with your 4-year-olds, your 5-year-olds, your 6-year-olds, and certainly your teenagers. But it starts throughout development. So we do understand a little bit about this from human development. What we've learned is that adults can learn these techniques too. And I'm hoping to develop new medications and new approaches that will allow us quicker ways to make some of these changes. All right, so that was a sidetrack around a lesson that the balances and connections that exist between these areas. These are normal brain systems related to reward, memory, and inhibitory control, all may be disrupted in addiction. This isn't like a stroke, though, or a tumor where it's a completely abnormal situation. These are variations in normal behavior. So these are normal brain circuits that are off balance as opposed to being completely pathological. And that's actually one of the hardest parts, is that I can't do surgery. I can't block a whole area because this is part of what makes us human beings. But the question is, so how do we modify and adjust these things? And that's the goal of treatment. All right, so that was principle number 1. That's why I'm not going through all 13, because it's kind of a chore and there's a lot to learn. But that's probably the most important part of my talk today, is to help you understand some of the neuroscience underpinnings. And because I think it helps us, gives us a little insight into the behavior of our patients, some empathy for them, and also an understanding that if you're going to change those pathways, it's going to take time, repetition, and reinforcement. Addiction certainly can be treated. We know that even the brain differences will improve over time, so that's a reassuring issue. I'll go through a few of these other principles now. It's a balance of rewards and sanctions that can really help. I've mentioned the importance of immediate responses to infractions. That's a key lesson, and we'll come back to that. And so the closer you link rewards and sanctions to a targeted behavior and keep it simple for the offenders, the more likely you are to have success. That's one of the principles. Tailoring services to fit the needs of the individual is key. We heard a little bit about this during the earlier session, that high-risk clients are those particularly who need frequent follow-up. And this is from some very nice work out of drug courts by Doug Marlowe and colleagues, showing that he tested how frequently should people be seen in a drug court system. Should they be seen on a regular basis, like every 2 weeks, like clockwork with automatic appointments, or can some individuals be seen less frequently? And what he shows is that for low-risk individuals, it doesn't seem to make much difference whether you see them often or less often. Well, that becomes easy then. If I don't have to see somebody all the time, it's less expensive, less intrusive, and they can go about their lives, and we'll see them every few months. On the other hand, for high-risk individuals, meaning those with antisocial behavior or history of significant drug problems in the past, they do need to be seen more frequently because they're much more likely to have problems if they're not seen regularly. Co-occurring problems in terms of mental illnesses need to be addressed in an integrated way. I haven't been to your conference, but I've certainly gotten a sense that this is a key theme for you all in dealing with mental illnesses. So robust relationships with the mental health providers will be essential. And paying attention to when somebody's not acting right, are they on the medication that was prescribed to them? That can often be a clue. You might recognize some of the behavior changes in your well-known clients. Treatment planning needs to focus on medical conditions as well. In particular, we've known that certain chronic infectious diseases are frequently seen in these high-risk populations. You may not know that about 14% of all people in the U.S. with HIV infection come through our one correctional facility or another in any 1 year. About a third of those with hepatitis and about 40% of those with tuberculosis will be in one of our correctional facilities at some time during a given year. So these are major targets for screening and intervention. One of the issues that's we've highlighted recently that's really an unfortunate lesson is that even among persons who are prescribed antiretroviral medications during their incarceration, many of them don't take these medications once they're released. That's due to both the systems of care that don't provide ready access to medical care. I think it also speaks to the chaotic lives and difficulties offenders face when they come out of prison or jail. And that taking a medication that will be life-saving in the long run, but really doesn't do much in the immediate circumstances is not high on their priorities. So what can we do to increase our ability to keep people on these life-saving medications? It might help the individual. It also may reduce their likelihood of transmitting HIV to somebody else. So it's not just good for them, it's good for our communities to figure out how to have more robust chronic models for, in this case, HIV treatment. I'm going to talk a little bit about some interventions. There was a question earlier about what shouldn't you do? Well, research has shown us that a few things are not just do we not have knowledge, we know these are ineffective. Incarceration all by itself doesn't do anything for drug addiction. Boot camp, intensive supervision, these are not effective. These are proven ineffective for addressing drug addiction. On the other hand, we have a number of interventions that have been proven effective for criminal justice populations. Residential treatment, contingency management, and medications. There are multiple promising approaches where we need to gather more evidence, but we certainly, they look much more likely than not to be useful. And then there's some real gaps in our research in terms of the Savory reentry initiative, reentry in general we need to focus on. And so there's areas for lots more research, and that's what I like to fund and support. But that's a general review. And if you have questions about that, send me a note and I can provide literature to back those up. I want to target just two more things for you. One is that medications are essential. Now, medications for addiction come in multiple forms, and this has been a really difficult message to get across to criminal justice providers, that offenders are at risk for relapse when they come out of prison, even though they've been in prison for a long time. This was a study done in Baltimore with heroin addicts who'd been incarcerated for years. And they did three groups. they compared those who were referred to methadone as a possible intervention when they were released from prison, those who were actively engaged in methadone treatment. So you essentially had a caseworker making an appointment for them, telling them where to go, and rehearsing how to get to the methadone clinic when they were released. That's the middle group. On the right are those who were started on methadone for the last few weeks during their incarceration. And this took the warden to have, I think, some bravery. It's one of the few cases where we have a few jails in this country where methadone or medications might be used, but it's almost unheard of medications for addictions in incarcerated populations. So this was just before release for the last few weeks. Now, what happens to them over the next few months? In green, we see engagement in treatment. So it's pretty clear that if you are just referred to treatment, but we don't do much as a system to encourage it, people don't go to treatment. In red, you see that about 70% of them relapse to heroin, to opioids, mostly within the first 2 weeks after release, and certainly by 6 months, the vast majority of them had relapsed. And about half their time involved, or about a third of their time involved participation in one crime or another. So very high rates of criminal behavior. On the other hand, those who were referred to treatment and engaged in treatment prior to release, that's starting, in this case, methadone prior to release, we had more engagement in treatment, much less likely to have a urine positive for heroin or opioids, and much fewer crime days. So we see this engagement in treatment can be important for both the public health and public safety outcomes. Now, this isn't a panacea. Methadone certainly isn't going to do anything about cocaine or stimulant use. It's designed specifically to target heroin use. But I encourage you to take another look at methadone and buprenorphine and these opioid replacement programs as an evidence-based approach that's frequently overlooked in criminal justice settings. And for many of these chronically affected individuals, it'll be the only thing that'll help save their lives. Apparently, I had some repetition there. I'm not sure why. Treatment must last long enough to produce changes. This is the last lesson and comes from a very important study dating back. It started almost 20 years ago in the Delaware correctional programs. Jim Inciardi and colleagues did this study where they started a therapeutic community in the prison and followed it with aftercare. That means during a work release period of time, they continued this therapeutic community approach. Those who participated in the full model, both in the prison and aftercare, were much more likely to be both arrest-free and drug-free over the 3-year follow-up period. So this is no drug use at all detected on frequent urine drug screening and no arrest for anything at follow-up. Where those who didn't get any intervention had about a 30% likelihood of being arrest-free compared to around 70% arrest-free who did this full, pretty intense intervention, including therapeutic community participation in and after prison. So that tells us the importance of a long-lasting program and thinking long-term in terms of these chronic, complex disease. Okay, we're done. I went through a whole lot of material with you. The key lessons that I hope you'll agree with me is that our models that separate the treatment and public safety approaches aren't terribly effective. And by building on the elements of each of those that are the strongest, we have a much greater likelihood of impacting offenders and drug addicts in the criminal justice system. That's sort of the general lesson. Now, when it comes to the specific principles and the issue around the neuroscience, I've emphasized that we've learned a lot about brain structure and function, and that informs our development of interventions and certainly informs our understanding of why our patients do these irrational, crazy, and obnoxious things. And it's partly because their brains are affected by these substances. It plays a role in terms of the reward. It takes advantage of our innate reward systems. Their memories are hijacked, and they generally start out with poorer judgment and control, and drugs tend to make that worse. So we have our work cut out for us in trying to help people turn those areas around, and fortunately, we have some treatments and interventions that can be useful. Thank you very much for your attention.